Welcome to this Practicing Clinicians Exchange podcast. I'm your host, Daniel Reynolds. In this episode, we talk to Jona Tanguay, a physician assistant at Whitman-Walker Health and clinical instructor at Yale School of Nursing. They will discuss considerations to incorporate patients' individual circumstances and preferences to improve equitable access to HIV PrEP. For more information about Jona Tanguay, along with other podcasts, downloadable slide sets, and a point-of-care resource hub, visit the website in the show notes. Now let's get started and hear what Jona has to say about empowering patients to select the right PrEP for them.
Hello, my name is Jona Tanguay and my pronouns are they, them. I'm a healthcare provider and HIV specialist at Whitman-Walker Health, an LGBTQ-oriented federally qualified health center in Washington, D.C., and a national center of LGBTQ health excellence. I am a clinical instructor at Yale School of Nursing and vice president for education at GLMA, Health Professionals Advancing LGBTQ Equality, the largest and oldest association of LGBTQ and allied health professionals. Today, we will be talking about guiding and empowering patients to select the right form of HIV-1 pre-exposure prophylaxis, or PrEP, for them. We are fortunate to have several different forms of PrEP suited to different patients, different goals, and different clinical scenarios. And this will only continue to expand as we broaden our prevention toolkit. I, like many, are eagerly awaiting the results of the PURPOSE 1 and 2 trials investigating lenacapavir as a 6-month injectable form of PrEP. But first, let's take a bird's eye view of the public health issue. CDC data in 2020 found that 25% of the 1.2 million people in the US for whom PrEP would be recommended were prescribed it. While this is an improvement from 2015, we still have a ways to go, especially for key populations. Specifically, people who inject drugs, people who participate in sex work, people experiencing housing instability, sexual and gender diverse communities, also described as LGBTQ people, adolescents, women and transmasculine or gender expansive people assigned female at birth, and communities of color. It's also important to note that 51% of new HIV infections are in the southern United States. There are large disparities based on race, with people of color being far more likely to acquire HIV due to issues such as poor healthcare access and the deleterious effects of structural racism, heterosexism, and cisgenderism. Targeting these historically excluded key populations can be difficult, and varied forms of PrEP alone will not be able to close all the gaps. However, having a menu of different PrEP options that continues to expand helps us empower patients from varied backgrounds to access preventative sexual health care that better suits their needs in an individual context. Currently, there are 4 different options for PrEP. Option 1 is tenofovir disoproxil fumarate and emtricitabine combination tablets, or TDF-FTC, taken orally once daily. Option 2 is TDF-FTC taken orally on demand on a schedule of 2 tablets 2 hours before sex, then 1 tablet 24 hours later, then 1 tablet 48 hours later. An option coming from the IPERGATE trial, which only included cisgender people assigned male at birth who have sex with other cisgender men or people assigned male at birth. Option 3 is tenofovir alafenamide and emtricitabine combination tablets, or TAF-FTC, taken orally once daily, only approved for people assigned male at birth. The DISCOVER trial included cisgender men and transfeminine people, but not people assigned female at birth. And finally, option 4, long-acting cabotegravir for PrEP, given every 2 months, approved for both people assigned male at birth, including transfeminine people, and people assigned female at birth, inclusive of cisgender women and transmasculine people. It's important to note that both oral and injectable PrEP are approved for adolescents who weigh at least 35 kilograms, or 77 pounds, who would benefit from prophylaxis for HIV-1 infection. Adolescents are a difficult population to target, especially due to issues with stigma and parental involvement. A motivated adolescent may do well with oral PrEP, but for those that struggle with managing medication or fear parents or others finding it, injectable PrEP may be a great option to better reach this population. In general, no one form of PrEP is superior for everyone in a subpopulation. It's always important to consider the individual context. TDF-FTC, taken once daily, is highly efficacious and is the oldest and most studied form of PrEP. When it comes to people who inject drugs, TDF-FTC has the most data behind it, as the HBTN 83 and 84 trials for long-acting cabotegravir did not specifically target injection drug use. Therefore, in people who inject drugs who do not have other behaviors associated with HIV-1 acquisition, TDF-FTC would be the best option. While TAF-FTC is less studied in this population, theoretically it would work the same and would be a good option for people who inject drugs with bone or kidney issues, though GFR should still be greater than 30, or people who inject drugs who have an intolerance to TDF-FTC, such as intractable nausea. It's important to note that pills only work when they are taken. Rather than decide for a patient, it's important to have an honest conversation. TDF-FTC may be the most studied, but if a person who injects drugs does not like taking pills, is concerned about the side effects or monitoring, or just prefers an injectable, long-acting cabotegravir should be offered. In the trials evaluating cabotegravir for PrEP, many folks were unhoused, and keeping track of pills could be especially hard for people experiencing housing instability. As such, regardless of whether the potential acquisition behavior is injection drug use, sex, or both, cabotegravir is an important option that may be presented as preferred for a patient that would have a hard time taking pills. People understand their own natures often more than we credit, so it's important to let them make that choice and decide the balance between ideal efficacy, their personal real-world efficacy, and the features that are important to them. To that end, PrEP 211, or on-demand PrEP with TDF-FTC, is a great option to offer cis men who have sex with partners assigned male at birth. In the IPREGADE trial, more renal and nausea side effects were experienced with PrEP 211. So it's important to mention this up front. Estrogens may lower tenofovir levels, and thus PrEP 211 may not be a good option for people assigned male at birth or transfeminine people on estrogens. However, for cis men who have planned sex, attend sex parties, or perhaps are monogamish or in an open relationship with one steady partner and occasional planned external partners, PrEP 211 can be a valuable intervention. Public health officials in New York have embraced it by working to offer PrEP 211 alongside condoms and lube, which itself is a form of safer sex and HIV prevention, outside large sex venues or gatherings such as circuit parties and fetish events. While TAF-FTC was not studied for on-demand use, given its PK values and better absorption into the tissues, it is likely as good as TDF-FTC for on-demand use. Given the lack of data, it would be best that TAF-FTC on demand be reserved only for cis men with kidney problems or other reasons they cannot tolerate TDF-FTC who are not right for other forms of PrEP. Monitoring the safety of tenofovir-based PrEP regimens with creatinine tests and vigilance for signs of the rare but serious side effect, Fanconi syndrome, characterized by polyuria, polydipsia, and bone pain and muscle weakness, is essential. TAF-FTC is quite similar to TDF-FTC, but is gentler on the bones and kidneys and would be the preferred option for someone interested in daily oral PrEP with a GFR between 30 and 60, a bone disorder, or a related illness that poses a threat to the bones and kidneys, such as uncontrolled diabetes, age less than 25, or meth use, which weakens the bones. The exact effect of TAF on lipids and weight are a bit questionable. It is likely it causes or worsens dyslipidemia, and it is often hard to tell in comparison if TAF leads to weight gain, if TDF is weight suppressive, or a little bit of both. At this time, pre-existing elevated BMI or dyslipidemia is not an exclusion for TAF-FTC, but it's worth discussing these effects with potential patients. The more important consideration is that people assigned female at birth were excluded from the Discover trial, so TAF-FTC cannot be used in anyone assigned female at birth. This is a key population, and hopefully future research will evaluate if TAF-FTC is an efficacious PrEP option for people assigned female at birth who desire or need an oral PrEP option that is softer on the bones or kidneys or causes less nausea. TDF-FTC, unlike TAF-FTC, has been studied in people assigned female at birth, and its safety in people who are pregnant is relatively well established. For people looking to become pregnant or who are currently pregnant and want to start PrEP, TDF-FTC would thus be the preferred option if they are able to take pills. Long-acting cabotegravir is our newest PrEP option, and while it is important to consider its potential to the fullest, it's also important to do a lot of counseling, as patients are less likely to be familiar with this form of PrEP beyond advertisements. Cabotegravir is not superior to daily oral PrEP for people who are good at taking pills. In the HPTN-83 trial, 4 incident HIV infections were seen in people who had great adherence and appropriate drug levels. These patients had integrase inhibitor-resistant HIV and required protease inhibitor or NNRTI-based regimens. While more research is needed into cabotegravir for PrEP failure, this is important knowledge for people considering long-acting PrEP, as seroconversion in people adherent to daily oral PrEP is much less common. As long-acting PrEP becomes more popular, we will also be able to better understand this issue. It is recommended to measure quantitative or qualitative HIV viral loads, especially for patients on cabotegravir for PrEP, as part of routine monitoring. However, coverage by private insurers for these lab tests is limited. Another important pearl to remember is that patients with BMIs over 30 need a longer needle for the injection. The safety of long-acting cabotegravir for PrEP for people who are pregnant is not well established. In the HBTN84 trial, cabotegravir did not seem to cause adverse birth effects, but the number of pregnant participants was low. As such, cabotegravir should be reserved only for pregnant people who would not do well on daily oral PrEP for whatever reason. Other important counseling points to mention up front are that people starting injectable PrEP need to be able to take oral PrEP or adhere to strict safety precautions, such as complete abstinence or strict condom use for 12 months if they decide to discontinue long-acting cabotegravir for PrEP. Safety precautions such as oral PrEP should be initiated within 2 months after the last dose of cabotegravir, and these patients should be followed quarterly for 1 year after discontinuation due to the long dissipation tail of the medication and the risk for integrase inhibitor-resistant HIV development in patients exposed to HIV with subtherapeutic levels of cabotegravir. While this additional counseling is important, long-acting PrEP is a wonderful intervention for people who can't take oral PrEP or do not do well on it. The HBTN84 trial also showed it is a great medication for people assigned female at birth with barriers to taking oral PrEP, especially those concerned for side effects of oral TDF-FTC or with adherence issues related to stigma, fear, or pre-existing conditions. Similar to adolescents, people assigned female at birth may be less likely to understand the risk for HIV-1 acquisition and may fear discrimination as HIV infection is viewed differently in cis heterosexual culture. As such, cabotegravir offers a wonderful option that can empower patients to sidestep some of these issues and take charge of their own health. To some, there is no one right PrEP for everyone. We are fortunate that the PrEP menu continues to expand, but as it does, it is essential to counsel patients on all the risks and benefits of all of the HIV-1 prophylaxis options available to them and ensure proper monitoring and follow-up. Long-acting injectable PrEP is a valuable medication to close gaps in reaching populations with issues taking daily oral PrEP, such as those experiencing housing instability, populations that have difficulty accessing healthcare, adolescents who are not good candidates for oral PrEP, and more. Best practice is to lay all the information out and empower patients to decide which form of PrEP meets their current needs, capacity, health status, and preference.
Thank you very much to Jona Tanguay, and thank you to our listeners for joining in. As a reminder, you can view the full Improving HIV Prevention in Primary Care, the Evolution of PrEP program on our website in the show notes. As always, thank you for listening.